Thank you so much, sir. Now our next session is by a special person. It's Dr. Vinu Krishnan, Chief Medical Officer, Homeopathic Cancer Center, Mathew, Government of Kerala. And I know there are many fans because I have a few PG students from all the way from Trivandrum Homeo College. So we know what is he as a teacher. So welcome you, sir, for this session.
Good evening. Good afternoon. Maybe I started my journey a day before yesterday. So today, standing on this platform, I should bow my head to two iconic personalities who have influenced millions of hearts. One is the late Mathew sir, who have made a platform like this to interact. Actually, we need platforms. And the other is the legendary statesman, Dr.C. Okay. Last month, I had an opportunity to visit a great platform on integrative oncology, where the presentations were so exciting and promising that the whole world, rather the medical community in general, is going behind a common platform to how to integrate or how to bridge our lacunae in oncological field especially. But apart from our country, it's still a stigma lacking, or rather a dogmatic thought of our own doctors to how to integrate or where to integrate. So I would like to focus my topic on areas of possible integration and how we can do it, because it is always easy to say that we need integration, but no one could say where to integrate, or rather when to integrate. As one allopathic or one conventional medicine doctor hearing a good Ayush lecture, the meaning is obvious to all. So this is the basic idea where oncology starts or where oncology stands. We need a multidisciplinary approach, everyone should agree. But where is our position? To just clarify this idea, I made this slide. From here it is clear that we need a multidisciplinary approach, but where to fix Ayush? We all know that this is an add-on therapy or an adjunctive therapy, or sometimes it can be used as an adjuvant therapy. And moreover, whenever it should be extrapolated to a standalone therapy. At times, rather, we can use it as a palliative therapy. So, this is the exact position of Ayush. When we plan diagnostic staging, when we plan a treatment protocol, when we plan a treatment plan, just like we plan to make a house, first thing is we should draw a picture. In that picture, where we fix Ayush is the left-hand corner. When we plan histological staging, when we discuss on the multiple comorbidities of the patient, we could fix Ayush as one diagnostic and therapeutic variable. So what is integrative oncology? It's very clear. It's very clear. What is integrative oncology? This is a peculiar type of cancer care. Rather, a focused cancer care. Two things should be there. It should be patient-centered. Moreover, absolutely it should be evidence-based. So evidence-based, person-centered, special type of cancer which can utilize those things. Mind, body practices, natural products, lifestyle modifications. See the definition? It's very clear. Plus, the last point, from different modalities. There we need a broader range. That's what the great man has shown to the community, and that's why we are here. And myself and Dr.C are conference mates nowadays. In many cities we are meeting. Just last week we met in Kochi. So that's why we are here. See, I want to just narrate a curious story. Last week I met a person who is from Pakistan, who is staying together with a Keralite in the same room, cooking food, sleeping together, living peacefully. Can we imagine in India or Pakistan? But this happened in Middle East. So in UAE, they could live together. Rather, they could love each other. And the sentence he made was, "Janta ke man mein pyar hai sir, pyar tha, but bekar ho gaya." See, so we need platforms like Middle East. In Middle East, they can live together in one room, cook food, waiting for the next one to come to go for his own shift. In India and Pakistan, we can't imagine at this time. So that type of platforms we need to come to discuss and to make benefit not only ourselves but to the suffering mind, suffering simple common man. Eventually, he is the one to suffer. Just like we see in the Israel-Hamas issue. It's a common man who is going to suffer. So how can we lend a hand to him? So this is the idea which I told you. Shifting a medical modality in one fine morning, it doesn't mean integration. Addressing even a single symptom or issue, or addressing inevitable physiological problems by a doctor or by a methodology can be done as integration. For this, we need insight. We should invoke ourselves, or rather we should have a connection between our upper skies and our present status. Then only we will evolve as a person. Many times we might have multiple degrees, post-graduation, diplomas, but we might not have evolved as a person. When we evolve as a person, we develop insight. That insight brings our broadness. So this is a hexagonal approach of oncological care. You can fix this conventional medicine, homeopathy, Ayurveda, Siddha, Yoga, Anthroposophy. Anthroposophy is a European methodology of cancer care, which I took a postgraduate diploma from Switzerland. It's a peculiar type of cancer treatment using European mistletoe as a methodology, having subcutaneous and intratumoral injections. Mistletoe is used as a homeopathic medicine as viscum album, but there they use a distilled water injections. Music therapy, art therapy, acupuncture, acupressure, pranic healing. See, I have come across a hospital, a unique hospital in Switzerland, Clinic Alshine, where these facilities are there. All experts are there. If a patient is coming, they can make a tailor-made prescription. You can consult that department, you can consult this department, so the benefits will be accumulating for the patient. So this is a hexagonal approach. So oncological care in particular, rather, I think medical concept should be coming to this type, because when we are forced to prescribe a corticosteroid, when we are forced to prescribe a tranquilizer, which might affect his pancreas or liver in the future, a physician who has an idea of integrative medicine can definitely use one simple medicine from other modality. So how can we use a broad field of integrative oncology? In our center, I represent a center under Government of Kerala where we have exclusively cancer OPD and IPD. Now we are having 16 beds. Now the hospital is upgraded to 50 beds, where we have integrative oncology as both complementary and standalone. At times standalone, which I will show definitely in my coming slides. So these are our broad protocols where we use stage 4 lung cancers with multiple comorbidities and with indeterminate mutations. As you all know, in lung cancer now, the mutation studies, molecular diagnostics have made a broader expansion, rather it has extrapolated the treatment modality to a larger horizon, because earlier 5 years or 10 years before, lung cancer patient, the prognosis was bad, but when molecular diagnostics and molecular testosterone was introduced, the EGFR mutations, BRAF mutations, KRAF mutations, those mutations identified by molecular diagnostics have made the cancer treatment in lung cancer more successful. But EGFR mutations comprise only 40%. Or rather BRAF, KRAF, other mutations, only is a very little percent. So whether mutations are indeterminate or mutations are negative in stage 4 lung cancers, we can use this medicine as standalone. To prevent metastasis in a known case of primary malignancy after scheduled conventional medicine. This is another protocol we are following. In pancreatic malignancies after Whipple surgery, students or practitioners might have encountered pancreatic cancer, which is very fatal and which is very damaging as a prognosis wise. After Whipple surgery, we could use this. in single and multiple hepatocellular cancers, in whether AFP is high or AFP is low, there is a new sensitive marker, PIVKA1, protein-induced vitamin K1 factor, where AFP will be normal and the physician might think that the patient is not having hepatocellular cancer, but PIVKA will be raised high. So those type of cases with history of CLD means chronic liver disease, or cirrhotic history of, that is a comorbidity, whether it's categorized by child A or child B category or BCLC staging, then homeopathy can be used, where we are successfully using. Also, if the patient is unfit for TACE or TARE, as you all know, TARE is now just upgraded to microwave ablation. If the ablation is not effective or the lesion occurs again, or if the size of the tumor is below 2.5 centimeter, they can go for RFA. Now RFA has been modified to microwave ablation. If it's not possible, definitely this medicine can be used, and we have successful data of multiple HCC who have increased progression-free survival. In relapsed hematological malignancy, we are using this medicine. Not in primary case of hematological malignancy. Definitely, they have to consult conventional medicine. They have to go for that MTX therapy or whatever it be. But if it is a relapse, if it is a short relapse after chemotherapy, definitely there is a chance. Again, after surgical recurrence, whether it may be a loco-regional recurrence or a other side recurrence, just like in breast cancer, whether sometimes the cicatrices break open again, the patient, unfortunate lady may be experiencing the same recurrence, or other metastasis like that. So, or otherwise in TURBT or TURPT, if the patient is having a recurrent history of bladder cancer or prostate cancer, definitely we can help. Wide and disseminated mets. As we all know, if the patient is coming with a PET-CT report of peritoneal carcinomatosis or meningeal disseminated metastasis or leptomeningeal metastasis, that means the diffuse spread is there, definitely this can be used. Progressive disease after scheduled chemo, even after the patient took the correct dosage of chemo radiation, if the disease is going progressive, usually seen in ovarian cancer. We can see in multiple cases that after second line, third line chemo, again the tumor marker gets increased, making the patient unfit for repeated chemo. We can use this. So these are the broad protocols. Tumor marker upsurge, as I just told you, CA125 or CA19.9 or CEA getting increased after colonic cancer. Definitely use this medicine. The tumor marker should be controlled, because the patient might have undergone scheduled chemo, scheduled surgery or scheduled radiation, which makes him unfit for further assault in a short period of time. Definitely this medicine can be used. So that's the idea. Leave speculations and open up. We have to be open up. Not as students, not physicians. Sensitization should start from all levels. So just I told you, whenever we speak of integration, if it is a single event, it's a single symptom, that is integration. Usually we experience in general these type of assaults in a patient suffering with cancer, whatever may be the nomenclature, whatever may be the organs affected. Definitely if we going for a chemo radiation, he might experience this type of a low blood count, which may be occurring from a bone marrow reduction or myelosuppression or immunosuppression, CR, cancer-related fatigue, cachexia, which is very, very damaging cachexia, NNB means nausea and vomiting, loss of taste, appetite, glandular issues, skin, hair and nail issues. But considering this, the nausea and vomiting will be the most difficult thing to treat for a patient undergoing chemo. Multiple cases are coming because the patient can't even think of food, or even he can tolerate food making even in the other room. His appetite might be great, but he's unable to take food. One single medicine, arsenicum album, rather cuprum metallic M30. You just add on water. I remember a case from a gynecologist where she was presenting that she had her own oncological team. She had a patient, but the patient was a technocrat. He was an engineer who believed that homeopathy is placebo. So he was having that symptom, nausea. He has to undergo that chemo, but the chemo was unable to give because of the nausea. He was unable to take food. Then the doctor said, I will give you homeopathic medicine. Then the technocrat said, no, I don't believe in homeopathy because it is placebo. And still now the modus operandi is unknown. Then the homeopathic physician addressed the issue very simple, because she took a full glass of water, drop 3 drops of arsenic aluminum-30, none could identify the medicine. The patient took the medicine and the nausea was gone. So that's a very possibility. Even a physician, a cancer physician can give. That's why I told you addressing single symptom or single event is integration. Rather, don't think that the patient has to be taken to a next homeopathic hospital or Ayush hospital, nothing. Bridges are only when we stand here, but when we stand, fix our camera from a top, our bridges won't be there. Or rather, our boundaries may not be there. From here, I can see the boundaries here, but for a Cosmos camera, no boundaries are there. So these are the common issues. So when and where we can integrate, possible areas and appropriate time of integration. During and post chemotherapy, there is a good chance of integration. I just give you some only instances. Oral candidiasis or mucositis, which is the most difficult symptom. Even just now we are having a patient in our hospital now, terribly suffering. Even she can't take even a single drop of water because of the extensive candidiasis or mucositis, because of the chemotherapy. Surgeons, physician said that she has to wait, she has to take nutrition, good food, good water, everything. Till the subsiding of the symptom, we will start other chemotherapy. She reported to us acid sulfuricum 30. It's a homeopathic medicine, very simple to use. Acid sulfuricum or calendula 30. You just give this medicine. It will be simply addressed. There is another medicine, hydrasis, but I believe that acid sulfuricum 30 or acid muriaticum 30 will bring brilliant results. Nausea vomiting, yes. Now, don't think that only arsenicum based medicine, but it's the most common used medicine, and you will get a result out of 100, you can believe more than 90%. If it's a low blood count, you can use X-ray, radium bromide or cadmium salt 30. Cadmium salt 30 is especially for paclitaxel chemo or capecitabine, paclitaxel or capecitabine chemo. If the patient is experiencing a reduction in blood count, just give cadmium salt 30. This count will be increasing. Fatigue, which is the most difficult symptom. Fatigue is a common symptom in medical parlance, but when we come to oncology, fatigue is a difficult symptom to address, where we can use acetic acid 30 and alfalfa as a medicine. We are now going for a study whether we have taken cancer-related fatigue as a common symptom, and we are giving alfalfa to all patients. And the N sample will be much rather than our homeopathic studies with the low N samples. This study, if it is successfully, we can break out, the N samples will be more than 1,000. Then how we can say that whether alfalfa could be used as a general medicine? Because when we discussed this idea with the MBR Cancer Center, the director, Sri Narayana Kutti Warrior sir, he is a very visionary man. The director is just like C.P. Mathew sir. He is from an Ayurvedic background, so he has the idea of integration. Every time when he meets me, he says that think of giving a quality of life to cancer patient, because or think of some medicines, just give to us also, whether we would give. So like-minded great people are coming and thinking together, and the cachexia, CKL core. This CKL core can be especially used during chemotherapy itself, because chemotherapy may cause the patient with severe hot flushes, cachexia, and the peculiar appearance of CKL core. Whether the patient could only tolerate sour drinks. He or she always asks for sweetened buttermilk. That's a classical symptom. Or carbo animalis 30 can be used. These medicines are repeatedly validated in our hospital, so you can use it successfully. If it is coming to post-radiation, there will be skin, nail and hair changes, or fibrosis will be there, or atrophy will be there, atrophy to the glands, rather resulting in, if it is a CS cervix patient, definitely the Bartholin's glands got atrophied and the patient may experience a dryness of the area. Then we could give lapis alba, calcarea flow, thiocyanate. These are the medicines we really use for skin, nail or fibrosis stage. If it is a surgery, then post-hemorrhage and shock, these are the specific medicine. You try this strontium carbide strophanthus. If the patient has a shock, you know that multiple causage of shock is there, cardiogenic, hypovolemic shock. Shock is a common symptom of vasovagal syncope, as it is termed. It's a common complaint experienced by almost all physicians in his day-to-day life. we could successfully, what is the treatment? You just give the patient a normal saline. If the patient is having nutritional problem, you could add with the polybion that we are giving. But giving a medicine to make his BP up, because usually adrenaline or noradrenaline push is given for making the BP high, but viscamalbum or strontium or strophanthes can make the patient into a better state because of the surgical shock or because of the loss of cardiac volume. We could address those issues. So what are the challenges we are experiencing? The challenges we could specifically say is an active lesion is a challenge for whoever the oncology physician. An active lesion is a challenge. Active lesion is a challenge. Post-treated lesions are also a challenge because if there is a recurrence, that's a challenge. Tumor marker observed, another challenge. We all believe, or rather we all think in an order, think in a way that how the relapse should be shortened, or how the progression-free survival could be beautifulized, or how the overall survival rate could be achieved with whatever medicines we are using. But if there is a recurrence, and if the patient is from a low age category, or the patient is in a reproductive age, a tumor upsurge of tumor marker is really a challenge. The relapse in hematological manner, as I told you, we don't take primary hematological cases, but we are receiving cases directly from RCC, MBR Cancer Center, Malabar Cancer Center, where we are having some success. I don't say that it's a great success, but some flag signs are there, where in some relapse cases we could be successfully able to reverse the status, but this can't be said as a general because it's a very challenging situation, but still we are making a try on acute lymphoblastic leukemia or AML. In some cases there are flag signs. Another challenge is 5F. This 5F is very interesting to note. Fluid overload, you can name it as pleural effusion or ascites or whatever, but fluid formation is a challenge. Fever is a challenge. To manage a fever in a malignancy patient is a great challenge. With paracetamol it won't go, because malignant fever is something really difficult thing. Flatulency, rather gastric complaints, or frequency of acute disease. So I think these AF should be dealt with caution. Actually, there is a corollary. The world is behind F. Fashion, fun, food. The world is behind F. Fashion, when we think of fashion, the shoes, watch, hair, all comes. The world is behind F and physician is behind also F. Immunocompromised status, as you all know, this MAHA status, or rather a patient, yesterday also I received a patient having a dramatic history that the patient attempted a microwave ablation. After the ablation, the whole immunological sequences started. Then they treated for that. They thought that it was multiple myeloma. They went for that investigations. Then they diagnosed it as rheumatoid arthritis. No, none was saying it was a cytokine storm, because immunological markers were increasing. As we all had an experience after post-COVID status, there was a cytokine storming. So inflammatory markers, or rather immunocompromised status, is a challenge. A residual effect of treatment, it's also a challenge. Control of intervening infections. Intervening infection should be controlled. Medical doctors are very easy there. They could give antibiotics at first with control. But we Ayush doctors is struggling with this acute, because the patient may be in Ayush hospital. He is experiencing an acute infection. Some itis, urethritis, cystitis, pneumonitis, or whatever it may be the itis. That's a challenge for us. Then last but not the least, widespread mets. These are surgical challenges, scar formation, keloid formations, recurrence. Coming to specific chemotherapy challenges, we experience pancytopenia, which I told you, myelosuppression, count reduction, aplastic anemia, mucositis, alopecia, that physiological decompensation, loss of appetite, loss of sleep, hiccup. Chemotherapy challenges continue, but at least we should address these mood swings also, anxiety, depression, loss of sleep. And we always go for those parameters only. When the patient is in the inpatient ward, we could see these issues are more. Doctor, I can't sleep. What will happen to my family? Who will look after my wife? That's a good question. There may be many, but who will look after my children? So that's the biggest question we face. Another is failure of optimization of electrolytes. Patient might experience a recurrent hyponatremia, which have many causes. CIATs may be a cause, or rather some pituitary pathology may be a cause. But hyponatremia, recurrent hyponatremia, whenever the patient is given repeated infusion, sodium either concentrated 3% NaCl or 10%, whatever may be there, we had a patient. He was on repeated infusion, but the sodium level was not getting high. Sodium, same with potassium, calcium levels. Again, the radiotherapy, which I have already summarized. Another biggest challenge is this cancer of unknown primary. I don't know how many doctors might have experienced this. This type of cases will come to you with a simple statement: cancer of primary unknown. Patient presented with metastasis. I had a patient. He was 6 feet tall. He was coming to the clinic very comfortably, just saying that I'm having a back pain here. Just when I have come from Middle East to get my daughter married, I have only 2 weeks of leave, but when I stand up, there's a lightning-like pain, like God's grace. Because of some intuition, I say no other complaints, no. But when this pain, what is the modality? No issues. Whenever I step back or raise back, there's a lightning-like pain coming. Do you have any other symptom? Sometimes I feel a paralysis of my lower limbs. You have some urinary complaints? No, as such. But I think there is some controllability problem. You just go to a physician, get an MRI done soon. He was asking, why? I am having only 2 weeks of leave. With this, I had to do all sort of things. But because of my persuasion, he took an MRI, and the result was very unfortunate, and the patient succumbed within 1 month. Because secondaries was there in the spine. Whole spread was there. So carcinoma of unknown primary is a very challenging thing that present clinically as these type of things. Fatigue, pain which is very not at all clear by modalities, maybe weight loss, bleeding, swelling, subcutaneous mass or thing. That is the international criteria of unknown primary, which we usually keep under our glass top. So whenever we forget something, if you put some mnemonics in your table, this will help you. Another thing is paraneoplastic syndrome. Patient may present with a recurrent hyponatremia or electrolyte imbalance. We may not experience what is the pathology. We can always think of a paraneoplastic pathology. This type of cancer can present with these symptoms only, increased parathormone or calcium levels, like that. So moving to our last session. These are the oncological emergencies. This should be borne in mind when we go for an oncology case. Because spinal cord compression, hypercalcemia, hyperuricemia, tumor lysis, infection. These are the oncological emergencies, including effusions also. So what is the goal of an Ayush physician or Ayush physician, or rather Siddha practitioner, homeopathy physician, whatever the goals we are going to set behind a patient? It's a progression-free survival. Go for a PFS. Whatever methodology, whatever medicines we are giving, you focus on a PFS. Good QoL, quality of life. Should control intervening infections. Complications should be prevented. If possible, lymph node regression should be there, because when we treat patient, we could monitor him, or we can keep the patient under surveillance for 3 months, 6 months. It's not possible to get a PET scan always, but we could go for ultrasound, simple ultrasound, whether we could check for para-aortic lymph node enlargement. So whether there is lymph node regression, metastatic reversal is possible in some cases, primary cytoreduction, and the last, escalation to a better state of health rather than the previous. Don't think that cancer can be cured, but a patient could be extrapolated to a more healthier status than the previous. That is our goal. So these are the experiences we get. Extended longevity. Progression-free survivals, the patient and the relatives are happy. Father or mother is still alive. Extended longevity with good quality of life, with those
auxiliary benefits. So what are the clinical outcomes for the patients? Patients feel that my health is optimized. That's a great parameter. Optimization of health should be there. Obviously rejuvenation in Ayurveda or Siddha, that rejuvenation is possible absolutely. We usually advise Ayurvedic medicines for our patients. After all, solace will be there. And the treatment compliance, this should be explained. Treatment compliance means if a patient is scheduled for a chemotherapy, an Ayush physician, it is his responsibility, it is social commitment. I think that that patient should be referred for chemotherapy, and if the patient is having a poor chemo compliance, you give some medicine and get him back to the chemotherapy. That is the duty. But unfortunately, some of the excited or rather half-type practitioners get more excitement and will boast that we will treat. That brings disgrace to the whole Ayush thing. Don't spoil the buffer time of the cancer patient. Usually when oral malignancies are present or OPD, we don't take it as primary because it should be dealt with a surgical oncologist or a team of oncologists. Otherwise, that buffer time will be lost. That time only an excision of below 1 centimeter will do. But if we go with further period, the whole half of the mandibulectomy will be needed in the future. So that should be their idea there. We should provide a treatment compliance. What will be the outcome for an Ayush institution? Our intervention should be focused and organized. That is the lacunae of all Ayush institutions or Ayush care. Our intervention should be focused and organized. We should have definite protocols, just like conventional medicine have. We should have protocols. In our center, it's almost 20 years we are running that center. We are having definite protocols. We don't take all cancer cases, and we don't boast that all cancer is curable. Our strategies should be bold. We have 5 types of strategies. We use prophylactic, we use palliative, adjuvant, add-on, complementary, and then palliative also. So what is the goal of a patient? It should be a tailor-made personalized medicine. As I just told, we can give homeopathy as in these type of strategies. In sometimes it can be given as standalone also. We have sufficient data in standalone cases. Addressing on specific lines, what we can address: pain control, infection control, skin and wound management. These are our IP protocol. This protocol we follow in our IP. When a patient experiences this type of problem, we will admit either for 3 days or 5 days, then try to control that. So what are the homeopathic medicines which can be used? For pain, this can be ABC is the idea, epismel, belladonna, C is for chamomilla or calcarea carb 30. Always homeopathic doctor should develop an idea that cancer is a multi-layered pathology. It's a deeper pathology. So don't think that medicines from plant origin or animal origin could cure. You should go and search and explore in mineral and metal kingdom. Then only that multiple pathology could be addressed. So ABC is our rule. For fatigue, aceticum and alpha-alpha-actic cachexia, candidiasis that I have already told, low blood count, these medicines we are using. For nausea and vomiting, acericum and epicare, cuprometallicum is a usually used medicine only with pain. For recurrence, if it is a genitourinary tumor, Staphysaccharine and Medorinum is the specific medicine we are using for recurrence. Post-chemotherapy, CKL, collapsed veins. This is a condition usually seen after chemotherapy. The patient may not get a venous line, so we are forced to go for central venous line. If he is having a collapsed venous state, Hamamelis 30 will bring the vein more patent. If it's a progressive disease, Melandrinum or Medorinum can be given. So before our last comment, just some glimpse of some cases. This is a breast cancer case. The patient did BCS, means breast conservation surgery, and we made an assessment for 48 months, that's 4 years. After the review scan, there was no mets. So that was a simple solitary tumor which got excised. After that, she took this medicine and she is under flow. This is a case of sigmoid colon, where we used this medicine alone, but this patient succumbed. This is a granulosa cell tumor ovary, where inhibin is a tumor marker, not CA125. Here the patient underwent surgery and chemo. Then our medicine was followed. Now the inhibin level is coming down. The patient was advocated a recurrent re-surgery, but with this medicine, the inhibin level is now under control and the surgery has been postponed. So hormone positive breast cancer, 4 years of observation. After review scan, only a liver lesion is there. Otherwise stable. The patient is still continuing to follow. It's a case of CS stomach, where the patient underwent surgery, partial gastrectomy and took homeopathic medicine. We got an observation of 14 months. CA prostate, patient underwent TERP, then took our medicine, PSA level stable, observation more than 30 months. CL NSCLC, non-small cell lung cancer, non-small cell lung cancer, period of observation only 6 months. But the thing is that repletion was, that's why I told you, metastatic reversal is possible in some cases. After phosphorus, we gave orometallicum. Whenever the pathology is deep, should take medicines from mineral or metal kingdom. So TNBC means triple negative breast cancer, where ER, PR and HER2 will be negative. So chemotherapy may be given, but no target therapy is possible. And we had an observation 24 months, no mets. We are having now a new study on triple negative breast cancer where we have almost 20 cases of triple negative breast cancer. We are trying to make it as a documentation. In the near future, we are trying to publish it. Another case of small cell lung cancer. As you all know, small cell lung cancer carry a very bad prognosis, limiting the survival period below 6 months. But here we got a 30 months of extended lifetime. He took homeopathy and he took chemotherapy and homeopathy as adjuvant therapy. Maybe it's time to stop. The system, that's the usual idea. When in class, after 45 minutes, everyone will get disturbed. I'm minding him. So this is a glioma case of recurrent glioma, 72 months. We got 72 months. That's a great period of observation. There you can see the medicines from which kingdom. It's a case of CA rectum with the lymph node base, observation period 60 months. So this is possible if we are running a center regularly, then we will get cases, and always try to speak if we are getting more than 24 months observation only. Otherwise, it may be a spontaneous regression, it may be an effect of the treatment which the patient is taking, undergoing. Don't boast that everything, every benefit attribute to Ayush. No. Whatever benefit we get, it's a combined relief. Again, 120 months. This is a magical case. The patient is still coming to our OPD. I don't know which God is saving that lady. So tumor is very large, but absolutely normal. Doing household duties. It's a medical miracle for the whole area. Now we are also surprised that whether the first report was true or not. But the thing is that tumor size makes us all laugh. It's a very large tumor, but the patient says, I'm absolutely okay. The great irony is that my senior doctor started treating that lady, and that doctor succumbed 3 years back. So this is a study on CA breast. We had a registration of 361 cases for post-surgical 29, homeopathy alone, triple negative 24 with BRCA1, BRCA1, BRCA2, two big topics to discuss here. Just giving an idea only. 164 hepatocellular cancer cases with progression-free survival of more than 24 months. So last new rays of hope. This is a case of CLN stage 4, 74-age male with upper lobe lesion and repletion with hilar lymph node enlargement. We used the medicine arsenicum iodate. Arsenicum iodate is a medicine which can be specifically used as in lung cancer and kali carbonicum. So case 2, this is again NSCLC. This is a case of CLM. This patient is still surviving, diagnosed in 2021 December, almost 2 years, no issues. PET CT review was done, no meds is there. Arsenic amyloidatum, we started from 6C, 12C, 30, 200, then switch off to LM potency. Now he is on arsenic amyloidatum 0/12. This is again a case of bronchogenic carcinoma. Stage 4 lung cancer, adenocarcinoma. This patient has been referred from Bangalore by an endocrinologist, where Kali carbonic was the medicine. Is under a good survival period, surviving more than 2 years, no intervening infections. So now it's the time for saying gratitude. We, our generation, need 2 things, I believe. We lack those 2 things. Gratitude for those blessings we are now experiencing. Our generation doesn't have a gratitude for such a hot, such a place, such camaraderie, such doctors, such institutions. So at least develop a feel of gratitude. The second is, don't argue for unnecessary things. You are losing your time, energy, creativity, everything. Most of the doctors are going with files in Supreme Court to challenge a system, or writing letters to authorities to ban a system. Why these patients or why these people are using their creativity in a negative level? What we gifted, what we got, just use for humane prosperity only. Don't try to. The same thing happened with the boasting doctors also. Don't try to boast or don't try to conduct press conference when we get a cure or rather an improvement health. Just keep on continuing on your work. Definitely the horizon will come. A word of gratitude to such a prestigious institution which had given me a golden opportunity, and Dr. Srijit, a word regarding Dr. Srijit. He visited my home and during the COVID time, and he gifted me with that precious Rudraksha which he meditated for more than 41 days in 64 days in such a terrific, the ritual way. So I remember, and because of him, I am here, and I thanks the organizers, and especially a word of thanks to my co-presenter, Dr. Shinto sir, who has given me a consent to present it more early, and that is his broadness of mind, because I have to travel again 8 hours in by road.